Ladies and gentlemen, welcome to the InPro Addiction Treatment Series webinar. Your host for today is Mark Lash. Mark, you may begin.
Thank you so much, Chris. Good afternoon, everyone, and thank you for joining us for our part 2 of the Addiction Medicine Series presented by Dr. R. Corey Waller. Before I introduce Dr. Waller, I just want to do a CE disclosure that I'm required to do and to let you know that Medistar, our partner in Wisconsin, is providing continuing education credit for this presentation. So we need to inform you that no commercial support has been received for this learning activity. The speakers and planners have reported no conflicts of interest. For CE credits or a certificate of attendance, you must attend the entire session and complete an online evaluation. Social workers, Michigan social workers will also need to complete a 10-question post-test, but that should not be a problem. And we encourage everyone to complete the evaluation to provide feedback on the session. And you'll need to complete the evaluation to get your CE certificate. So, and you will get an email probably within, since it's the holiday, probably early next week with a link to do the evaluation and to print out your CE certificate. And I'll talk about this at the end too. So let's just get right into it. I'd like to introduce Dr. R. Corey Waller, who's an experienced addiction medicine, pain and emergency medicine specialist based in Ann Arbor, Michigan. Dr. Waller currently works for Health Management Associates as a principal consultant. He is also the chair of the Legislative Advocacy Committee at the American Society of Addiction Medicine, or ASAM. Previously, he was the Senior Medical Director for Education and Policy at the National Center for Social Needs in Camden, New Jersey. Now, leading up to this, Dr. Waller was Medical Director of the Spectrum Health Center for Integrative Medicine, a unique complex care provider, actually a $5 billion health system in West Michigan. At the Center for Integrative Medicine, he helped develop innovative approaches to high-cost, high-utilization patients that were successful in treating patients with complex issues with care and dignity. In addition to being an outstanding academician and clinician, Dr. Waller is also a practicing emergency room physician. He and his family currently reside now in Ann Arbor, Michigan. So without further ado, I'll introduce you to R. Corey Waller, MD, who's going to talk to us about screening for addiction. Take it away, Dr. Waller.
Great. Thanks, Mark. I appreciate that. So for those on the call last time, we talked a little bit about addiction and kind of its origins and why it exists and really the system required to treat it. This time I wanted to get into a little bit more of the nitty-gritty of how do we even identify it, and in a practical way, not in a theoretical way. So we'll start with a bit of a theoretical framework, but we'll definitely at the end just drill down pretty deeply on not only what questions do you ask, but who asks those questions and what are the billing codes for it and how do we set it up. And then I'll make sure to leave plenty of time at the end for questions. So to start, I have no disclosures. I didn't have a disclosure slide in there, but no pharma, no device. But we use the word screening a lot, and I used to use it a ton too until I was directly informed by one of my colleagues who is a prevention specialist, MPH, who explained to me, you need to stop saying screening for everything, because screening doesn't mean screening doesn't mean screening, and that you need to be specific about what you're trying to evaluate. So let's walk through that real quick. So there is pre-screening, which is meant to be a rapid filter, meaning it's either a very quick question, an identification of a certain behavior, or a toxicological study that came back as positive, and that's pre-screening. And then you can go into screening. And screening is where you're starting to actually identify the risk of the disease, and then followed by, if that's positive, then you would follow into an assessment to determine the severity of the disease. And then if they have once you determine severity, then you can evaluate for placement, like where do they need to be. And you know, we do this all the time, whether we think about it or not. If somebody walks into your place of practice, and if it's a 23-year-old person with their exercise clothes on and runs 5 miles a day, that pre-screening really filters out a large portion of people who would need an evaluation for any cardiological disease from that point. But if they come in and they're, obese and they're 65 and they're sweaty and pale and are clutching their chest, then we're going to do another version of screening, and that would be an EKG. So an EKG would be a screening tool, and then the assessment for severity would be whether or not that EKG has an ST elevation MI, and if so, then we would place them into a cath lab. But if they don't, then we do other evaluations, and that could be assessments of the New York Heart score. We could look at other ways to score them for risk to determine if they're low risk, medium risk, and that helps us to determine whether or not this is a person who ends up in back out on primary care to get an outpatient stress test, gets admitted to OBS, gets admitted to the ICU. So all of those things we do on a regular basis. And so today I just want to really fill in each of those gaps with exactly what do we do for that for addiction, and specifically in primary care. So it's not only what are you going to ask, because this is a little more complex than if I was just asking, trying to identify cardiac disease. This one, because the disease itself creates disruption in the normal way that people interact, you have to actually frame the way that you ask in a question that's more motivational, and specifically motivational enhancement approach and motivational interviewing technique. And if you've never been trained specifically in motivational interviewing, that is, I will tell you, that works for so many things, and we talked a little bit about it last time, but that is really important, because if you change the frame in which you start asking the questions, what you will get is a subset of the population who you never thought would want or try to get help. It really engages in that further care. But these are some quick ways to start the pathway. And so it's very much, I'm going to ask you some questions. They're a little bit personal. I'd like to talk about alcohol and other drug use. I ask all my patients, so level set that so they don't feel like they're being separated out because of the way they look or where they're from or their level of income, and make sure that they understand that their responses will be confidential, like the other health information, and that the questions help you to really provide the best care. That's why you're asking. You're not trying to bust them. You're not trying to figure out if you can fire them. Well, I hope not. And what you're trying to do is figure out, where do I need to get you for care? Is here the right place? And if it is, great, then how do we do it? But if not, I want to make sure that we get you to the right location for care. And you do not have to answer them if you're uncomfortable. And that's a really important one. That one's tough. But quite honestly, if you start this off properly, I don't think I had, in the emergency department when I see patients now, which is different than when I was in the outpatient setting, I have no prior interaction with patients. They show up. I've never met them, mostly. And yet, they're pretty forthcoming if I approach it this way. And I screen every single person I see in the emergency department for addiction, and it initially starts with a verbal screen unless the pre-screen occurs. And that pre-screen, maybe they show up and they're intoxicated or they're status post-overdose. At that point, you skip, go, collect your $200 and start from there. But making sure that you ask the question, you set it up. Can't say that enough. Setting it up properly allows that patient to feel comfortable in answering truthfully, because I am sure that a number of people on this phone have asked the screening questions about alcohol use, and the answer is, no, I don't really drink. We know that a large portion of the population drinks alcohol, and if we were to look at the people that screened positive in primary care, it's well below the national average. And that's because a lot of people don't feel comfortable being honest with that. In fact, it freaked out my primary care when I was honest. And he's like, how much, well, do you drink? I'm like, yeah, I drink. Well, how much? I don't know, like 1 to 2 a day. So usually probably average 8 to 10 in a week. And so that's within the limit that we look at for alcohol use. But he looked at me cross-eyed. I'm like, yeah, I know. Most people probably tell you they don't drink at all. That's actually not true based on the research. So getting people to be honest is really, really important. So let's dig into what pre-screening is. So again, pre-screening is exactly what it is. You're just trying to determine if you need to take an official stance on how you're going to screen them. So it's really quick. It can be a self-report in the National Institute on Drug Addiction, which we'll go through these quick questions at the beginning, or you just send off a toxicological study. So we do this a lot if we're going to start somebody on a controlled substance, preliminary toxicological screen to evaluate for other substances in their urine. And so in doing that, it really sets us up to know risk. It doesn't tell us the answer about, severity or presence of illness. It just lets us know, do we need to check for it? So if you have a positive urine drug screen, that does not mean that a patient has addiction. That's not how we define it. We define it based on the behaviors associated with obtaining or using the drug of choice, or the behaviors associated with the behavior of choice, like gambling. So when we look at this, you have to make sure that you don't automatically see a yes or a positive in this pre-screen and connect that to a disease, because that's not, we're not there yet. So if we look at some of the pre-screening pathways, you have the NI-AAA one-item alcohol use question. So how many times in the past year have you had 5 or more drinks in a day? If you're a male, or 4, or it's actually now down to 3 or more for a woman. And then what the answer to that is, if the answer is yes on any of that, then it's a positive screen. So it's one quick question. It's specific. So it's not that, do you drink? It's not that, how do you drink often? Do you feel like you drink too much? It's not that. It's a very specific number, and it makes it easier for a yes/no question to be answered. And if the question is answered as a yes, then you would move on to evaluate for the risk. And then if need be, if that risk is high, then you would evaluate for severity. So if we go to for illicit drugs, again, there's still a single question for this. So how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? And this is the exact one that's been tested. So this is the validated one. Illegal, people understand that term. The term illicit gave differing results back based on the population that you were testing. But when they evaluated this one specifically, they found that it had a sensitivity of greater than 95% for presence of risk. So that's why this became important, is how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? And then a positive screen is 1 or more. I mean, it's not there's no scale. It's either if it's, once, that's positive. 150 times, it's still positive. And then it tells you to move to the next screening tool. So if we look at the ones that we can use as a pre-screen and what that looks like, these are the ones that are pretty common. So the cage, these are things that we were taught. That's about sensitivity in the 80% range. The audit, about 86% range. A 3-question drug screen, and from NIDA that we were talking about, and then the 1-question binge drinking pathway, and a blood alcohol concentration. So you can use those as kind of pre-screening tools to evaluate if you need to take them to the next level. And just as a reminder, if we start to look at the cage, we go through, do you feel the need to cut down? Do you feel annoyed when you're criticized? Have you ever felt bad or guilty? And then also, do you need the eye opener first thing in the morning? Now, interestingly, again, these are questions that if you read them as specifically as they are written, that's the thing that's validated. What I just did when I shortened it, that's not validated, because they're going to have an emotional contextual interaction with that patient. It doesn't always allow them to feel like they can be fully truthful as they're walking through on those. And we also tend to add our own little facial expressions and, raised eyebrows or, furrowed brows or, body language that makes them uncomfortable, as though we're waiting for the, quote, wrong answer. And so the best thing that you can do is have somebody read these, and it doesn't have to be you, and we'll get to that at the end, but have somebody read the question exactly as it's written. And you just tell them that. Go, look, we're going to ask you some questions. These questions are written very specifically, so I'm going to actually just read the question to you, and then we can have the answer from that. And then you just read it. Have you ever felt you should cut down on your drinking? Yes or no? Have people annoyed you by criticizing your drinking? Yes or no? Have you ever felt bad or guilty about your drinking? Yes or no? Have you ever had an eye-opener first thing in the morning to steady nerves or get rid of a hangover? Yes or no? Same tone. Very monotone, not meant to be like, you ever felt bad or guilty about your drinking? Or, I mean, really? People annoyed you by criticizing? I mean, no commentary. This is, no hyperbole. Just very specifically read the question. It's important because that is the way that it was validated. And in fact, when I watched some of the early study validations for the audit in the cage, it was as if a machine was asking it. It was just very monotone and very connected, and you look into your screen and not the person when you do it. If you're looking at the person, it changes the power dynamic and it changes the way in which they're going to answer. So read it off of the screen, listen for the answer, and just don't make a lot of eye contact with them during it. The 3-question audit of the version of the audit. Again, you can go through and how often do you drink anything containing alcohol? Never, less than monthly. How many drinks do you have on a typical day when you're drinking? And then how often do you have 4 or more drinks on one occasion? So this was also validated up in the high 80s for identification for sensitivity. And the sensitivity piece is what we want. We want to screen. The first one came out and it was like 98% sensitive. But then as it got used a little more in the real world and looked at in larger cohorts, then it's a bit high 80s, low 90s is where most of them end up on the meta-analyses. And then the 3-question pre-screen for drug use, and any yes is a positive. So in the last year, if you use drugs other than those required for medical reasons, in the last year, if you use prescription or other drugs for more than you meant to, and what drug do you use most frequently? And again, the question that's validated is the question you read. It really is important. NIDA has, really has the one question that comes down, and that's what looks, for binge drinking. This is the one question: when was the last time you had more than 5 drinks at one occasion? And again, any answer is positive. And that way, it tells you to move on. And a positive answer here only gives you the answer, yes, move to the next thing. And the next thing is where we start to actually screen for risk. And if we look, this is most of the things that we would use on here. And if you look, you have the assist. There are 8 items, and this is the next stage. So this combines a couple of things. So the assist and the full audit can also be used to determine risk and severity. And then if you have the DAST 10, you can use that for severity as well. This is all printed out at the end, so I don't mean to be confusing. But as we look through, these are the basic tools that are mostly used. All of these are validated. All of these are most likely in your EHR right now. You just have to pull it out. And then these are the ones that can be used in primary care. And generally speaking, it's going to be either self-administration or an interview. I always push for an interview process to happen because it also allows for you to have a little bit of coaching with that patient during that time rather than just being something that they fill out. I know it's hard to fit that in, but figuring out how to fit that in and either somebody else asks it and allows you to know coaching needs to take place, or you ask it and use it as a conversational pathway with the patient. So if we look at the full audit, this is an important piece. So now we have somebody who the pre-screen was positive, and now we're going to start to move forward and start to look at severity and risk. So when we look at this, we have the domains and item content of the full audit, and we go through, you have hazardous use, and that's frequency of drinking, the quantity of drinking, frequency of heavy drinking, and then we move into dependence symptoms. So do they have to continue to do it so they don't withdraw? So impaired control over drinking, increased salience of drinking, and morning drinking, and then harmful alcohol use, and that is guilt, blackouts, alcohol-related injuries. So what do we gain by increasing the number of questions that are asked? That's what always comes up. I mean, if they had a positive, what am I getting for this? Well, what this does is it increases inter-rater reliability, so the time in which the number of people who are asking it are the answers going to be the same in between them. And then the other piece is it allows for you to catch other symptoms that maybe weren't up with the eye opener. But if they have blackouts, or if they've had impaired control over drinking or an increased salience of drinking, the intolerance, if they have that, then maybe they don't have one in the morning, but all these other things are positive. So it allows for us to be able to move to the next level of understanding. And the score on the audit, again, 0 to 7, there's no problems at this time, meaning if we did that, then 5 years later, you should rescreen them. You can do an annual screening, but the data doesn't really show much from year to year, so unless there's been a significant life event, it's like a colonoscopy. If they score low, their risk at that stage of adulthood of becoming dependent on alcohol or other drugs is lower, so unless there's been a life event, such as a painful injury in a surgery, a death in the family, things like that, then there's no necessary reason to rescreen. So those life events are equivalent to having 3 episodes of blood in your stool at 2 years, and so therefore you may want to increase decrease the time in which you're going to get a follow-up colonoscopy. So it's, again, no real different. If you have a modifier that changes it, then you can move it up. But if that is negative, 0 to 7, then you're fine. You can just put that off and click the box, and then it'll be remind yourself to recheck it in 5 years. But if you start to move up to hazardous or harmful alcohol use, high level of alcohol problems and possible alcohol use disorder, and then probable alcohol use disorder, then this starts to get into where we're starting to have to evaluate for severity. Same for drugs, and if we look at the DAST-10, and if you look at all 10 of these, have you used drugs? Are those required for medical reasons? Yes, no. And you ask all 10 of these questions, and again, the DAST can be delivered either through self-administration, meaning they answer it while they're waiting, or it's asked by the nurse or the MA or yourself, as physician or PA nurse practitioner. Those are all acceptable ways to deliver this. And then after you ask those questions, then again, you come down. So if the score is 0, again, you're good for 5 years, and you don't necessarily have to pop that in. You're not going to hurt them by asking the question again. That's the difference between this and a colonoscopy, is there's very low risk to asking it again. So if you do it annually, that's not wrong. Generally speaking, that's an easier thing for implementation within a primary care. Is just to have it connected with all of the other things, and generally connecting the screening to something else that happens annually, like the flu shot. So if they come in for either their annual physical or their flu shot, those are the 2 times that you can generally do a quick screen for this. It seems a little out of place sometimes with the flu shot, but as far as patient feedback, but trying to get it any time that you can is important. And then as we start to look at really the matrix of what this should look like, if we start with the pre-screen, then if the pre-screen is negative, and remember the pre-screen was they had a negative urine drug screen, or they didn't have anything. You come in, you ask them the questions, they say no, and then you're done. And you're done for 5 years, unless again there's a life event. But if yes, the general pathway comes down for if you're positive for ETOH, then you're going to use the audit, and then if it's low risk, then that's a person you want to reinforce, the appropriate behaviors, monitor annually. We're going to go through specifically what that looks like in just a second. But if they're at risk and a little higher, 8 to 15, then brief intervention, lowering risk, decreasing use to safe levels, and then positive for illicit substance on the DAST. Then you basically do the same thing for risk with the using the DAST-10. So this is the general, and let me walk through each of these boxes in specificity so that we can understand it. So patient comes in, and you do the 1-question screen. In the last 1 year, have you had more than 5 drinks at once? For binge drinking, or say, do you drink more than 14 drinks in a week if you're male? If the answer is yes, then they move down to have the audit. You ask the 10 questions on the audit, and based on that score, that then puts you into the next level of where they need to go. So if it's low and you have an alcohol, you have a score of 0 to 7, and the DAS was 0 as well, then you just reinforce that positive behavior. And then I put on here monitor annually. Remember we talked about 5 years or annually. Depending on how you implement it is when you do it. Annual evaluation is, again, fine and probably easier with the EHR. The data shows that unless there's a significant life event, then you're pretty good for every 5 years with this. But if we go to the at-risk, meaning they're now they're positive for some of those things, so maybe they had a couple of times where they drink a little too much, maybe it affected their relationship, and this is where the brief intervention happens, and then trying to lower that risk by decreasing use to safe level. So interestingly, for the brief intervention for alcohol, the data is pretty good for utilization of the brief intervention. I mean, it decreases the use of alcohol by quite a bit. This works for tobacco as well. So tobacco's a little easier to screen for, meaning, do you smoke? Yes, no. All right, yes. Then let's figure out how to treat it. But the brief intervention becomes really important. So if a patient has positive at-risk alcohol utilization, a brief intervention sounds something like this. So when we did the screen, it sounds like ultimately what you did was you have a couple of times where you drink a little bit too much. What we do know is that when you do that, it can increase your risk of having an accident, whether that be a car accident, a slip and fall. In many people, it increases the chances of having a verbal accident, meaning you say something ridiculous and get yourself in trouble with the ones that you love or with the police. But at the same time, these are behaviors that I know that you're not looking for. I just have to tell you that it is worrisome, and trying to keep below that level is really going to be helpful. And if you feel like you need more help from that, then we can set you up with a conversation with counseling. But based on the score, it's fine. I feel like you're going to be able to really get past this. If you need to call in and chat, that's perfectly fine. But you know, you have to have another pathway of that intervention, and then you can go into, you know, what do you do for stress? Do you find that you're drinking because of stress? How is that? I mean, there are entire expert trainings that go through how to have that conversation. But the brief intervention makes a difference. It basically decreased the score by almost 50% on the follow-up audit. Now, whether or not that was because the patient had decided they didn't want to have that conversation again, or they actually decreased is a different story. But there was one study that followed patients out and did random screens for alcohol and did follow-up calls and also talked to spouses and loved ones to try to validate that. And they did see a positive impact on drinking and the same positive impact on smoking cessation. So the brief intervention is really, really helpful. Now, for illicit drug use, we don't have good data to show that it is helpful. That just chatting about, you know, you probably shouldn't crush and snort your Percocet. That doesn't seem to make a positive impact on how that patient behaves with that drug. And that automatically kind of scoots them up to more of the referral to treatment pathway or in-house treatment, which I think for that mild person, this is the perfectly built individual to treat them inside of primary care. Because in primary care, they can get all of the other stuff. And so if you're able to do something for opioids such as buprenorphine or naltrexone, and you're able to keep that patient engaged in primary care and continue, that's always the best. And this is really the better people. And if you did the screening for placement, which I'm going to talk a little bit about in a few minutes, but then it would tell you that it meets this ASAM level 1, which is outpatient treatment. And that outpatient treatment gives you the capability to see that patient more often. And so you would increase the number of times that you see them, probably maybe next couple of weeks from then, and then monthly for a little while, just to make sure that things are good. And if they do start medication-assisted treatment, then that's a whole different pathway. We're going to have that conversation. I think that's our next one. But but ultimately, right now, the brief intervention is important, but doesn't really suffice for those patients who are using illicit drugs. Definitely helps with tobacco and alcohol. If we move up to the moderate to high, that's where we start getting a little dicey. I mean, patients with moderate to high risk, if you were to use the DSM-5, would meet for a mild to moderate alcohol or opioid use disorder. And the DSM-5 is a little more complex to use, and that's why for primary care, I always feel like the audit or the DAS are helpful to give you that risk assessment. And the risk assessment is really helpful for knowing what you need to do next, as well as the severity. And it really connects the dots with a score, which makes it there. It's still pretty gray unless you do a lot of interactions with patients using the DSM-5 criteria. And quite honestly, if you look at the questions that are asked for the audit or the DAS, they pretty well fit what each of those are. There are a few things that are a little bit different, but ultimately there's enough overlap where one does equal the other as far as the ability to assess a patient without having to do a long-form standard evaluation. So when we look at this on the high risk, treat in-house or refer out. And we're going to talk a little bit about referral. I said use MI. Motivational interviewing is really, really important. And I'm going to say it over and over. If you have any CME money and you have any time, either do an online course or go somewhere warm, since it's now snow on the ground, I'm seeing out of my window, and go somewhere warm and learn about motivational interviewing. It will be the best 8-hour training you've ever done, because not only does it work with patients, but it works with bosses and wives and husbands and kids as well. I find it really useful with my 8-year-old to be able to actually talk them into doing math in the morning. So it's important. And if you don't use it, then what you're going to get is an escalation of behavior instead of conversation. So if you come at that person and you're like, look, when I look at this, you're at high risk, so you're misusing these meds, which means you have addiction. And if you have addiction, I can't write these for you anymore. So at this point, I'm going to have to stop the opioids, and we're just going to have to find you another place to get some help. That's really scary, and that's very high risk. Generally speaking, that pushes patients into outpatient high-risk behaviors at the house, high-risk behaviors trying to find these drugs. It pushes them into the emergency departments. So it's important to remember that when you evaluate a patient with a high risk, they have a disease that has a mortality rate attached to it. So if we had a patient with high-risk chest pain, we would really work with them, and we would modify our behavior so that we did the least amount of emotional damage to them, so that we would get them into treatment. So this is definitely one of those times that just the behavior that they have typically comes from fear and guilt and angst around everything that's going on. Don't take it personally, and utilize that motivational interviewing to help push them through to either engaging in treatment inside of the walls of your clinic, or utilizing a good referral pathway for some place where they can get help. But don't let them go until they've had the visit. That's really high risk. Make sure that you have a warm handoff with who you're referring to, whether that's an in-house referral to a colleague or a referral to a specific treatment pathway. Either way, it's really, really important to maintain that relationship. And definitely just be persistent. They may blow you off the first time. Don't take that as a no. Next time they come in for anything else, go through the same pathway. Give them a call. Have the nurse give them a call just to check in a week later. So the persistence becomes really, really important because a lot of people, when they first kind of, in their mind, get, quote, busted, they're not really busted. What we've done is we've identified somebody who has a risky disease with a mortality rate attached, and that mortality rate can be decreased if we continue to engage them to come into treatment. And treatment could be starting them on buprenorphine in the office at a low dose and seeing them on a regular basis and encouraging them to go and get cognitive behavioral therapy somewhere, or to be a part of group therapy, SMART addiction therapy. There's we'll dig into more of that in the next lecture, but ultimately continuing to push them, and you don't have to rescreen them every time, but definitely monitor them more closely and telephonically engage with them to get them to that point. So then we get to the high-risk group. The high-risk group is difficult because a lot of times they're going to not necessarily be showing up in primary care. So the ones that you do get, if they've answered the questions truthfully, and you get someone who has a higher severe risk, they are ready for help because they do generally one of two things. They don't answer the questions accurately, and so they don't show up, and they typically bounce out of the pre-screen because they answer no to the one question test. Or if, let's say you had a positive urine toxicology screen, then they deny, and say, I don't know what happened, I'm not sure what the problem is, and they push away. Well, that means they're living in that kind of pre-contemplative stage, and they're pushing against it. That's also a person who I would continue to follow up with and keep a close eye on. But for those that say, yes, I feel that, I do that, and I'm worried, those are people who are ready for help. They're seeking out the capability to get better because they've been truthful in that situation, and they have made themselves very vulnerable. And this is a really important thing to remember, is that if a patient does that and we screw this up, then they may not ever come back, not only to your clinic, but to anyone, because they have lost the trust and the capacity for feeling like we're going to help them at all, because they had that moment of vulnerability and we blew it off. So if you get a patient who scores high, this is eggshells and kid gloves. This is kind and motivational and consistently interactive. And we have to sometimes turn it off because sometimes these patients are frustrating. Sometimes they're a little angry. Sometimes they may seem condescending and agitated. Just recognize, like we talked about on the last call, that behavior is a symptom of the disease of addiction. And the approach to them is initially to continue to engage them in the primary care as best you can, but they're probably going to need a referral to a higher level of care so that they can have, just like you would for somebody with severe chest pain, they would go to a cardiologist. This is one that needs to go to an addiction psychiatrist or an addiction medicine doctor or a psychiatrist that feels comfortable with addiction, if you can find it. And I recognize fully that a number of the people on this phone call live in a place where they don't have that capacity. And so this is where we start getting into, as we design and develop and expand the addiction treatment ecosystem, and then when we do that, we have to do it in such a way that uses technology. And so this means it's probably time to connect with some telehealth modality so that they can at least be seen in your walls and figure out how to implement that into just the workflow in your office, which is not that hard once you do it. And then all of a sudden you find yourself using telehealth more so than referrals for endocrinology, for psychiatry, for addiction, for a whole bunch of stuff that doesn't need a direct physical exam. And that way the patient can still be seen and evaluated in your office, and you can bill for a nursing visit while they're getting set up. So this allows you to kind of be a multi-specialty clinic, even if you've just hung a shingle and you're working by yourself. But definitely required for that next higher level of risk individual. So when we start talking about the next phase, it's a bummer. I'll send this out so that it's easier to see. It just didn't transfer over well to the online. So when we look at this, this is the what we do and how we do it. So first off, who does the screening? So the screening is done by a medical assistant or an LPN or an RN or the self-screening. But again, asking the question directly engages the patient, and I would highly recommend figuring out how to make this a standard interaction rather than just filling out the same paperwork before you come in and get seen, because we all know that when that stuff gets taken out, it doesn't get input into the computer before you get to see them. And then many times it doesn't even flag it properly, and it's just I went and saw a pain doctor the other day for herniated disc, and it's the first time I had seen him, and I walk in, and I mean, I do interventional pain, and so I answered everything on there, and I know that big packet of stuff that I gave him, he had no inkling of it. I had the whole conversation again, and it was kind of a waste of time to fill all of that out, and that's what every patient feels. So having the interaction and filling it out at the same time allows that to feel meaningful to the patient as well. And it doesn't have to be with you. It can be your medical assistant. They can do the screening while they're doing vital signs. And all you have to do is make sure you set up a little better vital sign area so that it's HIPAA compliant. But and then your RN or LPN who's doing the rooming of the patient. So it can be done in a number of venues, and by a number of people, but try to put that in to the SOP, the standard operating procedure. And then who pays for the screening? Everybody pays for screening. If you bill for it properly, I mean, the reimbursement's not bad. I mean, it takes about, at the most, and that's if the pre-screen's positive, the next screen is positive, and now you're looking at risk. That ultimately bills out under CPT codes for $30 or $30, and if it's a structured screening with a brief intervention, that bills out at $65. These are all things that are very billable and identifiable. And even in Medicaid, these things bill out pretty well, $24 and $48 respectively. And I have the CPT codes for how you would bill for it, as well as the H codes for screening. And it's my understanding that all of the MCOs in the state of Michigan pay for those H codes. I did call, I know Molina does, Spectrum does, Priority Health does, as well as Blue Cross does, and Aetna does. So, generally speaking, the MCOs will reimburse those, but you have to code for it properly. And so sometimes you may need to figure out, build it into your note a little better as either a doc phrase or as an ongoing field, so that you can quickly do drop downs for this. But the key is to get it no different than blood pressure. And most of the EHRs have the capacity for you to put this in, just like you're watching weight, so you can graph it. So you can do a PHQ-9, a GAD-7 for your depression and anxiety, and then just have this sitting next to it, and you can watch those scales. Interesting, if you overlay those data, as the severity index goes up for addiction, you generally find anxiety and depression go up as well, along with that. And that can be really helpful. So if you don't have the capacity to get it into your EHR, at least have a specific place identified, a folder, so that when it's scanned into the computer, you can easily pop to it from your the screen when you're seeing the patient. Those things may sound small, but we all know that if you don't do that, it just doesn't happen. There's just no way to do it with the volume and the rate at which patients have to be seen during the day. And you can have that screen sitting up there and have it be the first thing that you're seeing after a patient is wound. And I think that actually is a more effective means of evaluating how to frame your interaction with that patient. Because if you have a diabetic whose sugars are out of control, hypertension is not taken care of, and you walk in and what's pulled up on your screen when you sign in is the med list, you're going to focus on the meds. And I'll tell you, if that patient has an addiction, they don't give a crap about the meds. They're not there. They're not even close to thinking about how they're going to dose their insulin and should they be counting carbohydrates. No, they're moving into that survival mode. And if that's the case, starting with the thing that's the biggest offender of risk. And remember, as we talked about, those sentinel syndromes we talked about last time with addiction, behavioral health, poorly treated chronic pain, and cognitive disorders, if those are happening, your chances of stabilizing any of the other disease ailments are really low. And it's kind of a waste of everybody's time. And I know that that's the last thing that we want to do is waste time and feel like the thing that we're doing is of no value. And it happens that way sometimes. So implement this so that you can bill for it and so that you can track it. Because if you can bill for it and track it, then you can act upon it. And then it also gives you the capacity to show the patient how things have gone up and down and have a really open, directed conversation about their mental health, as well as the substance utilization. And this is something that should occur on a more regular basis when you're evaluating patients. All right, so let's jump into the ASAM criteria. So we talked about a pre-screen. We talked about an actual screening for risk and then screening for severity. So this is the screen for placement. And this has been around since the mid-'80s. It's been developed and incrementally improved over time, and now is the standard evaluation pathway for someone who meets criteria. So now they've met criteria for a substance use disorder, and when they've met that criteria, then this means we need to identify where they should go. We look at 6 different dimensions in order to determine that, and so that is dimension 1 is, are they in withdrawal? Are they acutely intoxicated? And you need to explore kind of the past and current experiences for that, biomedical conditions and complications that come along with this, emotional, behavioral, and cognitive conditions that are complicated from the utilization. The readiness to change, are they there? We talked about pre-contemplation, contemplation, preparation, action, those phases. And then relapse or continued use, and where are they on that? And then recovery and kind of living environment, where are they within that realm? So this is a pretty nebulous 6 things if you don't do this for a living. And even if you do this for a living, I've seen this done so many different ways that if you just make it up yourself, it's not valid. It's a great approach almost for anything that we're talking about. But specifically now, there are tools that are online and implementable in primary care. And one of those is the ACAM criteria continuum co-triage tool. And the co-triage tool is about a 10 to 15 minute Q&A that can be done by a medical assistant. And what it does is it asks a lot of the same questions that you would ask on the audit or the DAS. But if you've already had that, it can pre-fill out the screening tool. And then you answer the other questions, and then it tells you where they need to go. It's a quick look. The real tool, the deep dive tool, is about an hour-long evaluation, and that only needs to be done inside of the specialty care environment. But the co-triage tool allows you to know, you know what, I need to send them to a methadone clinic. I mean, that's just where they belong. I can't really take care of it here. Or they need residential treatment, or they need intensive outpatient treatment. It lets you know where they should go. And then the delivery, again, it's an online tool. It can be done by anybody, and it is paid for as a part of the expert payment. But if you use the tool, you're combining a lot of the pieces of that, and so it ends up being worth it at the end, because for 15 minutes you're getting $65 in reimbursement, and you can set that up in the room so that that can be done on a computer there or on a tablet. So let's say you do this evaluation, the continuum, it's going to spit out a result that says they need to go somewhere. And these are the levels of care that they would need to go to. So first, you would go to 0.5, early intervention. Early intervention is expert. That's what it is. So if you're doing screening, brief intervention, and referral to treatment, that is level 0.5. And anybody who's at risk, that's the person who needs that brief intervention. Level 1 is outpatient. And above that is outpatient or level 1 opioid treatment program, which obviously is more intense than just regular outpatient services. Level 2 is intensive outpatient, and then you have a couple of different places in there, so IOP and then partial hospitalization. And what that has to do with is how many hours a week are these people being seen, and who is providing that care, so what licensure level is delivering that. And then you have residential or inpatient services, which is level 3. So residential is not residential. I mean, you can have a residential place where you pet horses and sit around a campfire and chit-chat, or you can actually have a residential program where you're getting medication-assisted treatment, you're seeing master's level or PhD level therapists, and having psychiatric evaluations in that. So saying that they need to go to a residential facility, it really is important to understand what level of residential facility they need to go to. And if they need a 3.7, which is this is intensive inpatient services, which means they're seeing a provider on a regular basis. They're checking out their medical conditions and taking care of those complex medical conditions, including withdrawal if they need to. And then if they're sick, like they're going to have significant alcohol withdrawal syndrome, or they have other comorbid conditions or co-occurring psychiatric illness, then these are patients you need to go up to a level 4. And that level 4 is medically managed, where basically it's an ICU. It lives within a hospital or inside of a psychiatric hospital, and it's built to handle sick patients within the addiction continuum. So that is the place where they would go as we would walk all the way through it. And then if we come down for just the end of it, and then we'll flip it over to questions. And so we routinely screen for things that are a lot less impact on the current health. I mean, hypertension is something to screen for, yes, but it really takes 20 or 30 years for that to have a massive impact on somebody's health. Addiction is immediate, and so it's important that we start to implement this. And we can, because it's paid for. And then, there are real-time interventions that can be onboarded in primary care, such as the brief intervention, but also medications. So medications for tobacco use disorder, alcohol use disorder and opioid use disorder that significantly decrease utilization and frequency. So it's important to understand those, and that's part of this process is us helping you to onboard the knowledge and really the sophistication and the confidence to start implementing and using these medications in primary care. And then there are places to send the patients. You just have to identify them and for your location. But again, quote, sending them somewhere may have to just be to a telemetric, provider in your, telemetric intervention room, which now in every new primary care, you just basically need a room that's set up to do high fidelity, telemedicine, especially in the rural areas. And so and you get a facility charge with that, which is interesting. It's a whole different conversation, but there are ways to bill for it and set it up so that it's sustainable and helps your patients. So that's the crux. You got a pre-screen, then you screen for risk, then you screen for severity, and then you get down to screening for placement. And so it's implementable. It's pretty straightforward. It can be done by a medical assistant to a pretty high fidelity, but I would definitely always want it to be done by the provider if you have that time and capability. So with that, turn it back over to Mark to facilitate questions, and then happy to answer those.
Thanks so much, Dr. Waller. Chris, could you let our listeners know how to ask a question?
Absolutely. Ladies and gentlemen, if you have a question this time, please dial the number 1 on your telephone keypad. Please dial the number 1 on your telephone keypad. And I'll give you all a moment to allow the queue to build up.
Thank you, Chris. Dr. Waller, while we're waiting for questions, I'm going to go back to your first presentation. Could you explain to us the concept of hyperalgesia?
Yeah, for sure. So the best way to describe hyperalgesia is if you have a stimulus, a painful stimuli coming in through the spinal cord to the brain, it's going to give off a signal intensity. If I give a drug that blocks that signal, the body doesn't like that because it knows it needs to send the signal, so it actually cranks up the signal intensity, both at the dorsal horn of the spinal cord and in the periaqueductal gray in the brain. And as well, even peripherally, you can have increased risk of, bradykinin as well. But, and then we would call that initially tolerance. They're like, well, the pain med's not working as much. And so then you add more opioid to cut up that pain. Well, then the body just increases the signal again. And each time that it increases the signal, there's a certain part of that through epigenetic changes that locks in. And so as you continue to go up, they now have a baseline of pain that's not being generated from the area of injury, but it's just being continually generated as a baseline from the dorsal horn of the spinal cord and the periaqueductal gray. And the only way to get that to reset down is to get them off of the opioid, and then over time, that will go down, typically over a period of a week to a few weeks. And all of the studies that have looked at this, where you have a patient who's got severe pain out of proportion to the injury, or pain to a non-painful stimuli, that their pain is either, when you get them off of opioids, their pain is either the same or less for 98% of patients on that piece. And I mean, we could get into the subcellular pharmacokinetic piece where you're talking about opioid receptor like 1 and some of the changes in the G protein coupling and adenylate cyclase increase that you're going to get inside the zone 2 of the dorsal horn. It also changes basically the NMDA feedback loop, so you get less inhibitory signal that comes down in zone 3 of the dorsal horn. So we know the science of it pretty well now, and so it's not a guess anymore. It's not a theory. We really do know that it is what happens.
Thank you very much. Chris, do we have any questions?
We do, actually. Our first question will be from Jonathan Nolte from Pro Healthcare. Jonathan, you may begin.
Could you speak to the age codes and CPT codes for screening? My WebEx, I couldn't get the slides up, so I'm just listening in.
Yeah, no, that's fine. So the CPT codes for that, and for some reason the graphic on the regular computer looks fine, but CPT for alcohol and substance use structured screening and brief intervention for 15 to 30 minutes is 99408.
And you said that's 15 to 30?
Yeah, 99408, and that's $33.41, generally speaking. And then the CPT code for more than 30 minutes is 99409.
All right, 99409?
Yeah, and then those are for commercial insurances. And then for Medicare, those same codes are G0396 and G0397. And then for Medicaid, those are H as in Hilo 0049 and H0050.
Okay. And anybody can implement that, or does it have to be a physician?
No, it's so I believe so. Each provide that's the one piece that's a little different. As long as it's certified by the physician, it's paid. So that means you've seen it and checked it off, and you can bill for it. So if that screening took place for 15 minutes, and then the brief intervention was done by a nurse, then you can bill for that. But generally, it has to be from a licensed professional in order for it to be delivered. Some of the commercial insurances narrow it to the physician or NP or PA, and I'm not sure which specific one. They're all a little different depending on products as well, of course. So you can't really predict. But generally speaking, if you bill for those and you sign off on it because you saw it and it was actually done in the office, it doesn't seem to matter from a billing mechanism who actually did it.
Okay, thank you.
Mm-hmm.
Chris, do we have any other questions?
We do. Our next question comes from John Glover of Metastar. John, you may ask your question.
Hi, Dr. Waller. Appreciate the great presentation. One of the things that I heard you mention that I have actually had some questions about is whether or not the 3-question audit or the 10-question audit might be able to be used as a monitoring device. Do you have any information on that for subsequent follow-up?
The 10-question can. It has enough fidelity that you can use the 10-question for monitoring. The 3 is one of those, like, remember at the beginning when we were talking about pre-screen versus screening for risk versus screening for severity? The 3-question would screen for risk. And then so if you're just looking for risk, meaning they've been all, they were 0 to 7 at the beginning, and you're now doing it, you can just use the 3 for continued, screening. And then if that comes back positive, then you can bump it up. So yeah, you can use the 3-question just to screen for risk. If you're monitoring the severity of something, however, you would need to use the 10-question version.
Okay. And then if you would expect those scores to decrease over time despite the questions being sort of in the past year?
Yeah, well, so that's where the subtlety of that is where I start to use the DSM-5. That's what I started using because it was easier. And the DSM-5 does sit in the EHR. So I think the DSM-5 questions, once you've identified that they have a use disorder, walking through those 11 questions for the DSM-5, it's also just a really nice mechanism for building a billable note, having a good conversation, and doing that. So it ends up being a really good structured interaction with the patient if you just walk through those 11 questions, and then you can also track that one for continued severity over time.
And you think that is available in the EHR for primary care, say?
I have not found an EHR that doesn't have it somewhere. Now, half of them you can track it. The other half you just have to go back to the last visit. But I just built it into my note when I was doing it, and would put the yes/no by it, and then that way it was always sitting in a field in my note if it was a patient that I was using it in.
Yeah, great idea. Thank you.
Yeah.
Okay, Chris, I think we have time for one more question if we have any.
That was it.
Okay. Thank you. So I guess we'll just go ahead and close. Again, thank you, Dr. Waller, for a fascinating presentation. I think you got at the heart of what we were trying to communicate to our practices and our partners that we invited to this event. So thank you very much. Just a quick reminder, your CE evaluation link will come in about 5 to 7 business days to your email address. Complete it. and there'll be a method to print out your CE certificate. Just want to remind you guys that the final webinar in this addiction medicine series is going to be next week, November 27th at the same time, 12:30 Eastern Time, 11:30 Central Time, featuring Dr. Waller. Dr. Waller will also be presenting on December 4th on a webinar topic, chronic pain for nurses and social workers, and that would be a way for nurses and social workers to get their single credit CE for their licensing requirements. So please join us on that day too. Again, I want to wish everyone a very, very happy Thanksgiving, peace and blessings to all of you. And again, thank you, Dr. Waller, for your time and wonderful presentation.
Yeah, no problem at all. Thanks. And if there are specific questions, feel free to send them in, and I can answer those in a more specific way.
Yeah, thanks. You can send them actually to my email address, and I can forward them to Dr. Waller. It's mloush@mpro.org, and I'd be more than glad to forward questions to Dr. Waller for answers. Okay.
Great.
But Chris, I think we're all set today.
Excellent. Well, ladies and gentlemen, at this time, you may now disconnect.